Hello and welcome. Being a nurse today is challenging. More and more, there seems to be a fundamental disconnect when it comes to nursing. Society and sometimes even major governing bodies view nursing through an outdated vocational lens. They see it as a simple collection of physical tasks, like giving an injection, dressing a wound, or checking vitals. Recently, the U.S. Department of Education even caused a stir by classifying certain nursing programs as vocational trades rather than academic sciences. This perception is completely wrong. It is dangerous to patient safety and it stifles our professional growth. My mission with this channel is to correct that narrative directly. We are officially shifting away from the old framework of stop failing nursing, and we are entering a new chapter, nursing as science. We must prove that nursing was not born from domestic chores. It was born from data science, epidemiology, environmental design, and complex systems theory. On this channel, we ground our work in the core truth that science leads to nursing theory. Medicine focuses on the disease, but nursing science focuses on the complex human response to that disease. To change how the world values our skill, we must look at the data and the structural battles that built our academic foundation. In order to understand our scientific identity, we have to examine how our pioneers broke away from institutional exploitation. In our first video segment, we are going to look at the history of nursing education in America. This footage explores how early hospital administrators used the promise of training to secure a continuous pipeline of free manual labor, and how nurses aggressively fought to establish autonomous, rigorous programs within major universities. Let us look at the historical record of this institutional tug of war.
Walk into an intensive care unit today, and you will see highly educated medical professionals titrating intravenous strips, analyzing telemetry data, and actively diagnosing patients. Earning this level of clinical authority required a deliberate escape from an institutional system that was specifically built to extract cheap labor from caretakers. For centuries, nursing existed outside formal academia. In ancient Egypt, wet nurses and dry nurses held deep respect within their communities, sometimes even linked to the divine. Even without universities, these early practitioners relied on codified medical knowledge. Surviving papyri contain highly complex surgical instructions and pharmaceutical formulas used to treat severe trauma. Because this knowledge was passed down informally, early nursing lacked a protected academic structure. When modern hospitals began to rise, the profession was entirely exposed to institutional capture. In the late 19th century, the American hospital system exploded in size. Suddenly, urban centers needed massive workforces to clean, feed, and manage thousands of sick patients. Administrators pitched a solution in 1873, opening the country's first Nightingale schools at institutions like Bellevue Hospital. They promoted these programs as a revolution in clinical education. The reality was a grueling apprenticeship. First-hand accounts show hospitals used the promise of training to secure a continuous pipeline of free labor. Student nurses worked massive shifts, primarily scrubbing wards, hauling coal, and managing the building's physical upkeep. Actual scientific instruction was treated as an afterthought, with physicians occasionally dropping by to give brief, informal lectures to exhausted students at the end of their shifts. The hospital boom successfully formalized nursing, but strictly confined it to a subservient labor class. The next several decades became a prolonged fight over who actually controlled the future of medical science. By the early 1900s, nursing leaders saw the inherent conflict of interest. Hospitals prioritizing their own immediate staffing needs would never provide rigorous academic training. To prove this, they turned to the Rockefeller Foundation, which funded a massive investigation into the profession. In 1923, they published the Goldmark Report. This bar chart illustrates their findings. The data revealed low admission standards, staggering workloads, and a near-total absence of science. With scientific instruction shrinking to zero in many facilities, the report concluded the hospital-led model was broken actively preventing the development of advanced professionals. Nurses realized that improving patient care required completely abandoning the apprenticeship model and forcing their way into institutions of higher education. Howard University initiated this shift, becoming the first institution in the country to integrate nursing education into a collegiate setting. Yale University quickly followed. Backed by a $1 million Rockefeller endowment, Yale established the first fully independent, university-based school of nursing. Instead of hauling coal on hospital wards, students were now sitting in formal classrooms, receiving Ivy League tier instruction in anatomy, physiology, and evidence-based science. Armed with high-level academic degrees, nurses possessed clinical capabilities that quickly outgrew the constraints of the traditional hospital. Stepping out of the hospital entirely, pioneers like Lillian Wald established public health nursing, bringing medical interventions directly to impoverished communities in New York City. Other highly educated nurses took on specialized roles inside the operating room, safely administering anesthesia during surgeries and managing complex obstetric care as midwives. Securing academic independence broke the cycle of hospital labor, turning localized caretakers into widespread public health innovators. By the late 20th century, the institutional tug-of-war heavily favored higher education. A university degree became the undisputed gold standard for entering the profession. This rigorous academic foundation created the modern advanced practice nurse, including the nurse practitioner, a role holding the clinical authority to diagnose illnesses and prescribe medication. A landmark 1994 New England Journal of Medicine study showed patient outcomes managed by nurse practitioners matched or exceeded traditional physicians. Deployed across primary care networks, advanced nursing safely solved massive national shortages. The fight for university education was a practical mechanism that enabled nurses to independently manage the health of millions of Americans. Today, nursing stands as the largest healthcare profession in the country, deeply integrated into every stage of medical intervention. Their expertise is continuously refined through high-tech clinical simulations and active participation in cutting-edge scientific research. The exhausted hospital apprentices of the 1870s have been replaced by the university-educated medical leaders operating today's critical care units. By refusing to remain a cheap labor force and demanding a seat in the university setting, nurses elevated their own profession while expanding the capacity, safety, and reach of the entire medical system.
As the historical record shows, moving our education into universities allowed nursing to transform from a hospital task list into an independent public health science. But this scientific approach did not just stay inside university walls. It was immediately deployed to solve some of the most severe healthcare crises in American history. In our next video segment, we travel to the rugged, isolated mountains of 1920s Kentucky. We will analyze the data-driven blueprint of Mary Breckinridge and the Frontier Nursing Service, proving how an autonomous network of horseback nurses completely shattered national maternal mortality averages.
In the 1920s, the Appalachian Mountains of Kentucky were almost entirely cut off from the rest of the country. There were no paved roads, no railway lines, and no easy way in or out of the dense forest. This deep geographic isolation created a silent crisis for families living there. Pregnant women and infants faced incredibly high mortality rates because accessing a hospital or finding a trained doctor meant a treacherous journey over miles of rugged terrain. Mary Breckinridge understood that grief firsthand. Born into a prominent, wealthy family, she enjoyed a privileged upbringing, but her life was marked by the tragic loss of her own 2 young children to illness. Following their deaths, she channeled her mourning into action. She committed the rest of her life to a single, highly focused goal: ensuring that mothers and babies in the most remote pockets of America could survive childbirth and early infancy. She looked at the standard American healthcare model of the era, which relied on building large, centralized hospitals in major cities, and saw that it was unusable for those isolated by the terrain. After World War I, Breckinridge traveled to Europe. She found herself working in the heavily bombarded, infrastructure-poor regions of northern France. Volunteering with the American Committee for Devastated France, she joined mobile relief units delivering supplies and medical care directly to displaced populations. Watching these nurses operate in ruined landscapes, she recognized a viable pattern. If a patient could not reach a clinic, the clinic had to travel to the patient. To see how a system like that could work on a permanent basis, she traveled to the Scottish Highlands to study the Highlands and Islands Medical and Nursing Service. There, she found a medical network operating in harsh, rural terrain entirely without doctors. Instead, it relied heavily on highly trained nurse midwives who practiced autonomously out in the wilderness. By observing the French mobility and the Scottish autonomy, Breckinridge had discovered the exact logistical blueprint she needed for Kentucky. She would build a decentralized network of professional nurse midwives. In 1925, she returned to the United States and founded the Frontier Nursing Service, or FNS, in the mountainous terrain of Leslie County, Kentucky. She designed a hub-and-spoke model. A central hospital served as the hub, branching to remote outpost clinics in the hills. Each was positioned so a nurse could reach any home within a 5-mile radius, creating overlapping coverage zones that eliminated geographic blind spots. Because vehicles couldn't navigate this roadless territory, the nurses traveled entirely on horseback, riding through blizzards, floods, and a relentless downpour to reach their patients. While they specialized in delivering babies, these women functioned as the primary public health officials for their entire districts. They tracked infectious diseases, ran immunization clinics in one-room schoolhouses, taught families to sanitize drinking wells and outhouses to prevent waterborne illness. This structured network allowed the FNS to provide professional medical oversight across hundreds of square miles of roadless territory. The effectiveness of this model is found in the service's long-term health data. Over its first 30 years of operation, the FNS attended thousands of births with remarkably low mortality rates. This chart shows the maternal mortality rate for the FNS compared to the rest of the country. While the United States as a whole saw 34 maternal deaths per 10,000 births, the Frontier Nursing Service recorded just 9.1. Achieving those numbers required specialized expertise. Because the United States didn't have any formal midwifery schools at the time, Breckinridge originally staffed her outposts almost entirely by recruiting trained British nurse midwives. That pipeline collapsed in 1939. When World War II broke out across Europe, many of those British nurses had to pack up and return home, leaving the outposts dangerously understaffed. Rather than let the system fail, Breckinridge built her own labor supply. That same year, she opened the Frontier Graduate School of Midwifery in Kentucky to start training an American workforce. What began as a local relief mission had, out of pure necessity during a global crisis, evolved into a permanent educational pipeline for American nursing. Over the following decades, that wartime midwifery school continued to expand, eventually growing into what is now the Frontier Nursing University. Marking its 100-year anniversary in 2025, the institution has trained thousands of advanced practice nurses and treated tens of thousands of rural patients. The horses have long since been replaced by modern vehicles, but the core ethos of sending highly trained practitioners outward into the community remains fully intact. That approach is just as relevant today. Many rural areas in the United States are currently classified as maternal health deserts, lacking nearby obstetric care or birth centers. Mary Breckinridge's century-old model proves a point that still holds true. Geographic isolation does not have to mean medical isolation, as long as the healthcare system is willing to make the journey to the patient.
Reclaiming this history is what gives us the collective power to fight back against federal misclassifications and defend our professional identity. Now, I want to speak directly to the nursing students who are watching this channel. To successfully navigate this rigorous field and fight back against the devaluation of our work, you need a clear strategy. You cannot master this science through shortcuts or simple memorization. You need resources that respect your intelligence, honor our legacy, and guide you through the systemic complexities of advanced clinical reasoning. You can access these foundational blueprints right now through the clinicalnursepro.com website, where you will find guides and mini courses geared to help with your success in nursing school. These courses and guides help you understand what you are learning in class by breaking down the skills and concepts you are expected to know, as well as nursing theory and historical truth applied directly to clinical practice, classroom mastery, and systemic wellness. We also know that surviving the clinical and academic pressures of this discipline requires absolute balance. That is why we integrated our custom student wellness app directly into this educational ecosystem. This app is designed specifically to help you maintain your personal wellness and mental stamina while navigating the intense stress of your nursing program. But the app doesn't stop there. Once you graduate, the app transitions with you into practice, helping you organize your daily workflows, tasks, and schedules as a new registered nurse. Let us move past the vocational myths and claim our rightful authority as medical leaders. Explore the courses on clinicalnursepro.com. Download the wellness app and subscribe to join our community. And I will see you in the next masterclass.